So we will go to the topic. So you are learning genetics for last so many days, 10 days you are learning in and out of genetics. So now we will discuss something about what are the recent advances or recent concepts of treatment or genetics, therapy in genetic disorders. So if you take 15 years back, when I am doing my DM, in 2004 to 2007, this topic is much more easy to tell. Maximum we will discuss around 45 minutes. But now I think there are so many treatment options are available. So my aim is not to include or discuss all treatment options, because that is not possible. Because now there are so many new molecules are there, new treatment modalities are there. So it is a snapshot of how this treatment paradigm evolved last 20 years of genetics with some examples, clinically we using, etc. So when you use the concept of therapy, there are 3 C's are there, always, because always in medical schools, when you are learning the MD or MBBS, people will ask, why genetic disorders, why genetics? When I have came for DM genetics also, my friends asked, what are you going to do by DM genetics? You will sit under the microscope and do something like that. As madam told, we have got a basic understanding of genetics so that we are doing some genetic tests, some research and etc. But I am swearing in the last 15 to 20 years, 80% of my work is still clinical. So many things you can do for the patients and families affected with the genetic disorders. So naturally we will feel that there is genetic disorders, there is no cure. Everybody will tell there is no cure. Why are you doing to do it? So that is why the concept of therapy is important for genetic disorders. It is beautifully described in Scriver Textbook of Medicine. Textbook of Metabolic Disorders, sorry, not medicine. So there are cure, control, and care. So cure means we are ablating the cause. We are basically ablating the cause, like B12 responsive methylmalonic acidemia. I have given only few examples of genetic disorders where you can totally cure the condition, or control, preventing the effects by various modalities like Wilson's disease, hemophilia, primary prevention by prenatal diagnosis, screening strategies, etc. Care, supportive for family, genetic counseling, psychological and social. So if you see management of genetic disorder in the holistic concept, you can do some treatment can be given to every patient. At least you can care the family, care the patient. Some supportive things can be given. That is also treatment. So if you see other diseases, cure, how many diseases can be cured? Most of the disorders cannot be cured. But we are telling that we are treating. For example, you take the one important concept of epilepsy. We are giving anticonvulsants for so many years, newer and newer anticonvulsants have came. But actually what we are doing, we are only controlling the epilepsy. We are not treating the cure. We are not doing anything. We know that some of the epilepsy like febrile seizure or something will not be repeated. So we will give one dose, we will control the seizure, we will send it back, nothing is going to happen. Or it will be much more things, some seizure disorders, some epileptic disorders, we will suppress the seizure activity by giving the anticonvulsants. But we are not doing any cure to the basic mechanism. That is why now the concept of precision medicine came. Even in epilepsy, now we are identifying epileptic encephalopathy, we are identifying the molecules, and some of these receptor diseases and newer molecules are coming for treatment. That is cure. So gradually everything should be cured. That we know. But practically, unnecessarily, there is a blame that genetic disorders cannot be cured. Most of the disorders cannot be cured. Everything we are controlling or we are caring. So genetic disorders can also be so many end problems, abnormalities that can be controlled. If you know achondroplasia, what are the problems child can get? What is the anticipatory guidelines we should follow? So many complications can be prevented. Proper advices can be given. Because yesterday also one example I will tell. Because GSD, even pediatricians, most of the people know GSD means they will tell that you should not take, because everybody knows only GSD1. They will tell that GSD1, you should not take the fructose, sucrose, everything you stop. But that patient mutation is GSD9. GSD9, that much stringent control of fructose and other things are not required. So now more and more information regarding GSD also, glycogen storage disease also you take. Each and every glycogen storage disease is having separate type of management is there. So management of genetic disorders, we can do a lot of things we can learn, lot of things we can do. So that doesn't mean, don't take it away that genetic disorders are non-curable. So many management options are available. This is the first important concept I want to do, concept of C therapy. Second thing is, if you go to the level of actual cure of genetic therapies, levels of therapy, you can start from a single dogmatic concept that there is a single gene will give a mRNA will give a protein will have some physiological function, which will have some metabolic function, which will have a normal function or normal physiology of the organ. So you can start from that. If there is a mutation, which is the best cure, the gene has to be corrected. That mutation has to be corrected, or gene has to be supplemented. That is the gene therapy. That is, gene can be edited, and that we will come to that later. Gene therapy or a transplantation. Transplantation, actually, the entire organ we are changing, so that the same protein can be given. So that is at the mutant gene level. Whereas in a mutant mRNA level, small interfacing RNA, where there can be some modification in the mRNA level can be there. Mutant protein, that is, there is a protein abnormality is there. We are supplementing the protein, like growth hormone therapy, factor VIII in the hemophilia, or enzyme replacement therapy in lysosomal storage disorder. Here we are not changing the gene, we are not changing the organ, anything. There is some enzyme is deficient or protein is deficient, that protein we are supplementing. There are so many examples under mutant protein or protein replacement therapy. Then again, protein also we are not replaced, that everything is there, but there is a metabolic dysfunction. Metabolic dysfunction means where is the metabolic abnormalities occurring, where we can modify according to dietary therapy in so many small molecule diseases like phenylketonuria, maple syrup urine disease, organic acidemia, etc. Some diets or dietary therapy can modify the accumulation of abnormal metabolites can be reduced, or if there is a deficiency of the product, that product can be normally given. Like in glycogen disease, hypoglycemia is occurring, so we will give glucose in between, larger amount of glucose or a cornstarch, everything can be given so that hypoglycemia can be prevented, hepatomegaly will be reduced. So many of these things can happen. Or pharmacological therapy, where this metabolic dysfunction can be altered. That means some vitamins can be given which will induce the enzyme, or some pharmacology drugs will be given which will obstruct, something like that. So these are all so many examples for this metabolic dysfunction correction. Then clinical phenotypes can be corrected, like Marfan syndrome, classical example. Marfan syndrome, if there is a aortic root dilatation, proper administration of propranolol will definitely prevent the sudden death. Definitely it is proven. So you have to give the beta blockers to patients with the Marfan syndrome and aortic root dilatation, so that can prevent the sudden aortic dissection and death. Similarly, so many other examples also is there. Then surgical intervention. So whenever there is a birth defect or some things which can be corrected surgically, that can be corrected. So this will help in the clinical phenotype. There, we are not changing the protein, we are not changing the gene, we are not changing the metabolism. Whatever defect has occurred, that defect has been corrected by surgical. And finally, every patient requires genetic counseling, prenatal diagnosis, screening, so that their burden of the disease in their family, their psychological things, everything can be improved. So some of the examples I will just put, it's not a comprehensive, some examples which I think most of the people will be knowing, like in hyperammonemia. One example in metabolic disorders like hyperammonemia, urea cycle disorders, sodium benzoate, sodium phenylbutyrate, all these things can be given. Previously, I used to present all these conditions single slide. Since now we are more other therapies, gene therapy, etc. came, I cut short into one slide. Just an examples of some of the hyperammonemia, urea cycle disorders, where you have to can give sodium benzoate and sodium phenylbutyrate, where will actually the ammonia scavenger, so that hyperammonia will be prevented, the mechanism can be improved. Then like chelation therapy, like Wilson's disease, we will give dipencilamine, and thalassemia and iron store content, you will deferoxarox. This will definitely improve the symptoms. That is another genetic disorders where chelation therapy will help. Some of the metabolic disorders, megavitamin therapy, like high dose of biotin in biotinidase deficiency. Similarly, pyridoxine dependent seizures. Administration of pyridoxine is totally about the seizures. then homocystinuria. So there are so many conditions. Riboflavin will be given, high dose riboflavin, glutaric aciduria. There are so many conditions where high dose vitamin therapy will help you, which will act as a stimulator or a stimulator to the enzyme, whatever remaining enzyme is there. Then mitochondrial disorders, we will give carnitine, coenzyme Q, etc. These are the mitochondrial cocktail, which will have some improvement. Definitely, I know it is not a cure, but there will be some improvement and symptomatic improvement will be there. Then osteogenesis imperfecta, most important thing is bisphosphonate. As you know, it is a standard of care of therapy. Now people should know that the people or children with osteogenesis imperfecta, if you start early bisphosphonate, definitely the BMD will be increased as well as the recurrent fractures will be prevented. That can be palmitronate, alendronate, solindronate, all those things can be given. Then Marfan syndrome, already I told propranolol, it's a classical example. Duchenne muscular dystrophy, corticosteroids, it's really, it's a controversial thing, but still people usually use it because it will have little bit limitation of the progression of the disease. But finally, definitely, that will not change the final outcome, but some extra years they may get, but you have to be very cautiously used because long-term steroids, again, it can produce all complications of DMD also, like myopathy it can produce, and DMD itself, they will be in the bedridden, so they have severe osteoporosis. This steroid therapy again aggravate the osteoporosis. So it is not a definitive therapy, but for the benefit of some improvement or something which nothing can be given, there plus some low dose of 0.75 to 0.9 milligram per kg of steroids, corticosteroids can be given. Then hydroxyurea and sickle cell anemia is the standard of care of therapy. Everybody knows because it will definitely prevent the acute attacks. And similarly in thalassemia, non-transfusion dependent thalassemia also, hydroxyurea will definitely give 1 to 2 milligram benefit of hemoglobin, so that hydroxyurea can be given in some of the thalassemia cases also. Then acute intermittent porphyria, the treatment of choice is IV hematine, which will help to manage the acute attack. So these are some of the pharmacological therapy. It is not a comprehensive list. Some of the common conditions which we will see in our practice. So this, I think, everybody knows it's osteogenesis imperfecta. It is not a condition which is properly treated. It is totally untreated case of osteogenesis imperfecta. It's a 10-year-old child presented with a severe limb deformities and X-ray. You can see that severe cyst cheese. That is, you can see that this is actually the vertebra. This is not the vertebra. This is the vertebra. Actually, vertebra is totally compressed because of the severe osteoporosis. And you can see the what is this? Something you are eating looks like. That is a classical picture of X-ray picture of osteogenesis imperfecta, where there is multiple fractures in the epiphysis. It will be calcified. So it is like no. It is not telephone. Is this multiple callus is there? Along with that, the end you can see there is something like cone calcification. Cones, just like small cones. The cones in a packet. So this is the classical picture of an osteogenesis imperfecta. Just I have in between one slide I put, that's all. So bisphosphonate is the treatment of choice for osteogenesis imperfecta, which you should not forget, but definitely it is having a significant improvement in the bone mineral density, and it will prevent the recurrent fractures. You can give alendronate, palmitronate, and solindronate. Solindronate is a long acting, so you can give once in 6 months. Palmitronate is an intermediate acting, once in 3 months you have to give. Alendronate daily oral, 5 to 10 mg per day. But there are so many other molecules also is there. I have put only which common available in India. So usually, previously we used to give palmitronate. Now we are also giving solindronate because there are so many studies on solindronate also, because previously solindronate in pediatric, there was not much study. People felt that there is a possibility of long-term accumulation of the bone and osteopetrosis like features and fractures. It may stimulate fractures. But now reasonable studies are there. I don't know. But solindronate is what we are using, and we are having a reasonable, against a reasonable improvement, but it will not help in the severe form of osteogenesis imperfecta with type 2 or severe deforming variety. Sometimes it may not benefit, but definitely in type 1 variety, where father is having multiple fractures and he is having difficulty in walking, etc., we are giving for so many children, and after treatment, number of reduction of fractures are markedly reduced. Type 1 is definitely it is a treatment of choice. And significant improvement in BMD scores and reduction in number of fractures. Side effects include hypocalcemia, bone pain, not to be given at the time of fracture. So that is why in the some of the type 2 patient problem is from birth onwards, they will have fractures. So they will say that after 30 days you will come, or after 45 days you will come, we will start again, next fracture will come. So type 2 patients and type 3 severe deforming variety, there is some difficulty in managing. Similarly, hypocalcemia also, it will occur only in the very young children. I am having only experience in young children. Some of the 3-month-old children, if we give this olendronate, that I have seen hypocalcemia, even hypocalcemic seizures post-treatment. But usually in the 3-year, 4-year, 5-year, those children, usually nothing is going to happen. Usually it will not happen, but always you have to monitor calcium, phosphorus, alkaline phosphatase, and hypocalcemia should be given, not to be given at the time of fracture because it will delay the fracture healing. Then emergency management of metabolic disorders with encephalopathy. This is just for one slide I have put because this is actually age bar for solendronate. No. There is no age bar because we are giving for other conditions, genetic conditions with the osteoporosis also, even DMD. In DMD patient, when they are having significant osteoporosis, after 10 years, 14 years, you have to follow up with the BMD, bone mineral density. But in a government setup, I am not doing bone mineral density routinely for these BMD patients. Similarly, osteogenesis imperfecta patients also. But clinically, if you feel patient is having significant bone pains and other thing, after 10 years, 12 years, we are starting. There is no age bar. But if already the patient is having multiple fractures, 25 year, 30 year, then if you want to do, that is your question? No. Minimum. Okay. In younger age, you should be very careful. That's I told. Minimum, there is no contraindication, but you have to be very careful. That is I told. It is very risky. 6 months on everything, usually we will not start because type 1 patient usually will come only after that. Only type 2, type 3 patient, even the very young age group. At that age group, most of the time they will have fracture. So you cannot give. But we have started 6-month-old children. There is no contraindication. Absolute contraindication is not there. But it is not preferable because there is a chance of hypocalcemia and other complications. Then emergency management always, you should know, it is mainly in intensive care and pediatric, kind of just for a completion's sake, because in any metabolic disorders with encephalopathy or metabolic decompensation, like organic acidemia, urea cycle disorders, usually it will pick up in the ICU with the emergency management. So you have to do ABC, correction of metabolic abnormalities, fluid management, removal of toxic metabolites, in severe hyperammonemia, and these things, peritoneal dialysis or extended transfusion may be required. Pharmacological therapy of hyperammonemia, already we have discussed sodium benzoate and IV arginine sometimes, but it is not freely available in India. Megavitamin therapy, sick day protocols, all these things should be considered in children with the small molecule disease, where organic acidemia, urea cycle disorders, and naturally diet also has to be given. Dietary therapy like dietary restriction of phenylalanine to maintain plasma count. This is one example I have put, 3 to 5 mg per phenylketonuria. As you know, phenylalanine will not be converted in tyrosine and it will convert to acetate, lactate, and pyruvate, which is the toxic metabolite. So if you reduce the phenylalanine in the diet, the toxic metabolite will not be accumulated in the body, which will prevent the end organ damage. Here, phenylketonuria, maple syrup urine disease, methylmalonic, propionic, isovaleric, tyrosinic, galactosemia, fructose intolerance, all those things, dietary formulas are available. Affordability and availability is not a major issue in last, I can say, 5 years because of the Indian markets. In India also it is can say manufacturing by Kristin company, so it is available. But it is not freely available. You cannot go directly to things, but now through online you can easily get the special diets, and you can start the diet when you diagnose or suspect a patient. And another therapy which will help in the disorders is the growth hormone therapy. You have seen 4 children with the short stature. One is growth hormone deficiency, which is typical proportionate short stature, cherubic face, and typically newborn at the birth length will be normal, then they will have short stature. Turner syndrome, it's a female with a short stature with a Turner-like phenotype. Noonan syndrome, Turner-like phenotype, but have different cardiac disease and some different dysmorphism, which is a autosomal dominant monogenic disorder. or achondroplasia, which is a skeletal dysplasia. These are all prototype of various conditions for short stature. That is a growth hormone deficiency endocrine cause. Turner syndrome and Noonan syndrome are genetic syndromic causes, and achondroplasia is the skeletal dysplasia. So this type of short stature, always parents are worried. How much my child will improve? What are the options are available? So you should be able to tell, and growth hormone is available. Indication for growth hormone therapy is children with the growth hormone deficiency. Turner syndrome. Turner syndrome, if you start early with a higher dose, they can reach a reasonable height. Because in our series, we have seen Turner syndrome, most of the time we are detecting late. We had most of the Turner syndrome, even in Kerala, we are detecting late. So most of our adult Turner syndrome height is somewhere around, I have non-treated patients, I am telling, it's around 135, 134, 135, maximum 140 centimeters. So definitely it is short stature. But if you started early, a pediatrician has picked it up, you can start growth hormone early. You have to give a little bit higher dose compared to growth hormone deficiency. Turner syndrome can improve, but not like growth hormone deficiency. Growth hormone deficiency, it is wonder. All my growth hormone, around 10 patients are there. They have started at 6 months, 2 years, at 12 years, 13 years, they are absolutely normal height. So that improvement you cannot expect in other conditions. So in Turner syndrome, Noonan syndrome, all those conditions, there will be some benefit, but not like growth hormone. Because growth hormone deficiency, it is due to physiological deficiency of growth hormone. If you give growth hormone, they will become absolutely normal. So that is mandate. We cannot say mandatory, but it is the standard of care of management. Rest of the conditions you can discuss with the parents. There will be some improvement. Skeletal dysplasia, only Japanese things they have approved. You can give, but problem is sometimes there is a disproportion will increase. So I don't have any experience. Only 1 or 2 patients in hypochondroplasia they have tried and they have stopped. So I don't have much experience in skeletal dysplasia. I think it is not the cup of tea. It's not very good cup of tea because it will have a later they may develop a disproportion. Yes. Down syndrome. No, Down syndrome per se, we will not give growth hormone. Because usually in Down syndrome, growth abnormalities, one is more of a failure to thrive rather than simple short stature. So I have mainly considered the short stature features. The Down syndrome, basically, it is a failure to thrive in the first part of life because of congenital heart disease and other problems. If you tackle that issue and there is no congenital heart disease, most of the would have been seen. Infant Down syndrome will grow normally. Second part of flattering, they are occurring during the adolescent period. Adolescent and elder period, they will have finally they have a short stature. Finally, they are having short stature. So problem is their short stature will be somewhere around the moderate short stature. That type of short stature, how much you will give, when will you give? Because you cannot start early. Early, they may not have significant short stature. So Down syndrome children with a short stature, it is not a standard of care of management. But interesting thing is, the company will tell that every patient you can give. But that is true, because if you are administering growth hormone, there will be some benefit. But that some benefit is really benefit to the society or really benefit to the patient. That is the confusion. For example, hypochondroplasia also. Normally also they will reach around 140, 145 centimeters. If you give growth hormone or some treatment, they will get around 5 centimeter or 6 centimeter. They will reach 155 or 160 or something like that. So what is, for that you have to give a persistent long therapy. That's I told. The two benefits are important. If you not treat, patient will be 75 centimeters. If you treat, patient will be normal. That is a classical example of growth hormone deficiency. Whereas in other patients, even if you don't treat, they will be around 140, 135, that range. And if you treat, they will have some benefit. That is why I told these type of things we have to discuss with. Then there is a primordial short stature, SGA babies, small for gestational age babies. All those conditions, growth hormone can be given. FDA has approved. Chronic renal failure, FDA has approved. You can give. But those things you have to discuss. That's it. Small for gestational age, chronic renal insufficiency, idiopathic short stature, etc. There you can be given, but it has to be discussed with family. What is the benefit? What is the cost? What are the disadvantages? And that is why in Kerala, we have given a scheme. Our scheme is we will give only for growth hormone deficiency. And post radiotherapy or chemotherapy oncological patients. In these two type of patients, we are giving growth hormone from the state government free. But all other conditions, Turner, Noonan, we are not supporting. State government is not supporting, but in COE, Center of Excellence, we can include those. So now we are including those patients in that. Because in growth hormone deficiency, it is definitely improved. And the post-medulloblastoma, radiotherapy in the brain, etc., these type of patients definitely have a growth altering. Those patients, growth hormone, it is justified because they will have some improvement will be there. That is a acquired condition, acquired problem which develops. So that we are considering. So rest of the conditions we have to discuss with the parents. What are the benefits and discuss with them. Prader-Willi is totally different thing. Now it is considered as one of the treatment of choice, but it should be very careful because they can develop obstructive sleep apnea. So before that, so many testing like sleep apnea test, so many other tests you have to do before giving Prader-Willi, growth hormone to Prader-Willi. Doses are a little bit different because in Turner syndrome always a little bit high. Growth hormone deficiency, it is physiological dose. I think dose in English, I am not going to that. This is a practical aspect that also I think we will omit. So daily we have to give 6 to 2 times a week, subcutaneous administration in the evening. So pen is available. And a cessation of GH therapy at the end of the linear growth reaching an acceptable height close to target height, growth velocity decreasing less than 2 centimeters. And some of the monitoring should be done, like hemoglobin A1C should be done, growth monitoring should be done, and symptoms of benign. Because one common complication we used to see in growth hormone therapy is the benign intracranial hypertension. They will come up with the headache. Then you have to reduce the dose.
How common is it?
It is common means if you, I think 10 patients, if you give one patient will develop benign raised intracranial, then we will reduce the dose. Then they will be adjusted. Even in growth hormone deficiency, they can develop a headache. Headache is a very common complaint. In only 2 patients with the Turner syndrome, I was forced to stop because of the increase in hemoglobin A1C. So every once in 6 months, I used to see hemoglobin A1C. That is a recommendation. A growth hormone deficiency, so far it has not happened. But Turner syndrome, little bit older females, 12 years, at that time they developed a hemoglobin A1C above 6.7, 6.8. At that time we stopped it. Again, it came back to normal. Then coming to the enzyme replacement therapy, it is because I've told about some of the standard forms available like growth hormone. It is a concept due to a mannose-6-phosphate receptor mediated pathway, secretion recapture pathway. That is actually given for the lysosomal storage disorders. Enzymes are actually formed in the endoplasmic reticulum and it is transported into the lysosome by the mannose-6-phosphate receptor mediated pathway. So this concept was given by Dewey in 1964 that if you give enzyme from outside, we can inject the enzyme. If we can do some mechanism by which this mannose-6-phosphate can recognize that enzyme, that can be engulfed and put into the lysosome. So wherever deficiency is there, that deficiency can be corrected. That is called secretion recapture pathway. So enzyme replacement therapy is now available for Gaucher disease. I have put one enzyme that is only for just for understanding. That doesn't mean that it is a monopoly. Gaucher disease, we are having 3-4 companies are making enzyme. Fabry's disease, MPS 1, MPS type 6, Pompe disease, and MPS type 2. All these conditions, enzymes are available. Then MPS type 6 is available. MPS type 4 is available. Then Woolman's disease is available. Galactosialidosis, Niemann-Pick. Now it has already came and we are giving 2 patients on charitable access. We are giving for Niemann-Pick disease. So it is, that is I told. Previously we are having 4 diseases. Now it's around 10, 12 diseases is having PRTs available. In India, marketing, it is available for Gaucher, Fabry, MPS type 1, type 2, and Pompe. These 5 diseases, it is available in the market. That is DCGI is approved, you can buy. And Niemann-Pick disease, galactosialidosis, Woolman's disease, MPS type 4 and MPS type 7, etc. These are available through some charitable access program and other things. So there are so many enzyme is available. But one thing always you should remember, if somebody has asked me, which is having highest priority in this, I always talk about Gaucher disease. Because in my experience, as well as in the world literature, it is the standard of care management of Gaucher disease. Rest of the enzymes, there are some, we cannot say limitations, some selection of patients also is required. So Gaucher disease, symptomatic GD type 1 and type 3. Type 2, usually we will not recommend enzyme replacement therapy because as you know, type T is having neurological involvement, and these enzymes are large molecules which will not cross the blood-brain barrier. So in conditions with the neurological involvement, this is very difficult to correct the neurological involvement. So in GST type 2, type 3, it is recommended, but type 3 also we have to say that with a severe neurological, better not to give because neurological will not be cured. Usual dose of ERT is 60 units per kg every 2 weeks. Lower doses are tried in type 1 up to 20, 30, some studies are there. Dose is individualized depending upon the clinical status of the patient and not recommended in type 2, already I told. And reduction in spleen and liver size, improvement in hemoglobin and platelet count, growth and general well-being, reduction in bone crisis, prevents bone pain and serious skeletal complications, joint vertebral collapse and fractures. So in Gaucher disease, now bone marrow transplant is not recommended worldwide because, especially type 1, because bone marrow transplantation is having, definitely there is a risk of complications and even mortality during the procedure, whatever the best center you are having. Whereas it is a lifelong therapy, but later you can change to substrate reduction therapy. I will come to that, which is only an oral therapy candidate. So Gaucher disease, now standard of care of management is ERT. In comparison, somebody would have been feel why Pompe, why Gaucher type 1, MBS type 1, type 2, etc. In Pompe, you take Pompe is definitely it is the best care of therapy. But problem is, in some of the Pompe, they are severe enough at birth or 3 months. When you detect itself, patient is having severe cardiomyopathy. So even if you start the treatment, patient may not improve. Patient may not improve. So we have also seen some of the Pompe disease patient little bit delay in starting the treatment. So then naturally issues will come. You have to start in the newborn period itself. That is why in Taiwan, where Pompe disease is very common, they are doing newborn screening and they are starting ERT as the newborn screening. After newborn screening, they are detecting Pompe, they are starting and they are having excellent response. And now the Pompe disease who have the enzyme who have identified is also PriyaKrishnani. She's from Mumbai only, Indian only. She recently in a conference, she has told about the intrauterine. Also, they have started trialing because in some patients it is severely damaging. At birth itself, it will have severe cardiomyopathy. So that is I told. In those cases, selection of patients, all these things are a little bit improvement. Some patients may not improve. Similarly, MBS type 2 you take. MBS type 2 without neurological. There is a type of type 2 where there is no neurological involvement, significant joint contractures, adenoid enlargement, respiratory problem, cardiac issues. If you give ERT, significant, excellent improvement. One of my patients for 4 years, excellent improvement. He is now studying in 12th standard, now going for some entrance and other things. But he is absolutely not having any neurological involvement. Some of the MPS type 2, even 3 years, 4 years, they have a significant neurological involvement. They may not get that much benefit because it cannot cross the blood-brain barrier. Type 1 is also same issue. Every patient is not getting that much benefit. Some patients may get benefit, that's all. So that things you have to accept. But these are all some treatment definitely we can follow. So that is why in Gaucher disease, in IP also, guideline is there. Indian Pediatrics, 2018, first LSD guidelines published from our country as also. Hunter syndrome is individualized for long-term treatment of patients with MPS type 2, improves and or stabilizes several somatic parameters. And it is also reasonably good. I told you this non-neurological variety. For me, 3 patients are getting this treatment. And it's reasonably good. Pompe is also good. I'm not telling it is not good, but it has to be started at the earliest. In severe infantile variety, patient may not get that much benefit. MBS type 2, this is the patient I told, ERT for last 2 years, now it is 3 years. Improvement in joint function, cardiac status improved, severity of MR reduced. Now studying in 12th standard. So he's having an excellent improvement in MBS type 2. But since ERT is there, still we search for new treatments. So I thought from ERT, I will go to the other treatments like administered intravenously and tissue delivery dependent upon receptor, poor effect on bones and lungs in patients with severe pre-existing disease. That is why in MPS, if there is severe pre-existing bone and soft tissue, bone and diseases, sometimes it may be totally corrected. Does not cross the blood-brain barrier. In some of the cases, especially in Pompe disease, antibody formation is a problem. Rest of the conditions, I don't think literature also is not a very big issue, but some cases, Pompe is a major problem. Gram-negative patients, you will have a severe antibody formation. Then, just like in hemophilia, we cannot give the ART. So antibody formation, another problem. And most important thing is expensive and long-term treatment. For a 10 kg child, it is costing somewhere around 50 lakhs. And 50 lakhs for a year. And when weight increases, again cost increases. So I think it is a very difficult proposition to give in Indian context to give, but we are having some of the patients through various charitable access program, as well as some of the government organization and NGOs are supporting it. So there is an enzyme enhancement therapy. Here concept is low molecular weight chaperones, pharmacological chaperones are used to rescue misfolded or unstable proteins so that it can cross the blood-brain barrier, so that whatever misfolded protein, because in some of the missense mutation, protein is there, quality is not reduced, quantity is not reduced, quality is abnormal. So that quality change can be done by some of the chaperones. That is not for every conditions. Fabry's disease, cardiac variant of Fabry's disease is the first condition where they have tried with some specific mutation. I'm not going to the detail. Similarly, in Gaucher disease and some of the Pompe's disease, they are trying that, because you can also feel Pompe's disease. I told you there's a spectrum of manifestation. One spectrum you can see a infantile Pompe with severe cardiomyopathy at birth itself, and another spectrum you will see a limb girdle muscular dystrophy like features of a 24-year-old child, 24-year adult with the muscular dystrophy having a Pompe's disease. It's a milder variant. So in those type of patients, sometimes this enzyme enhancement may work up. Similarly, Gaucher disease, various spectrum is there. So these type of cases, some of the mutations where there is a misfolding occurs will be effective. Small hydrophobic molecules can reach target site, likely to be effective only in those patients in whom specific mutations does not inactivate the catalytic site. And substrate reduction therapy is also useful in conditions like Gaucher disease, where ceramide will change to glucosyl ceramide, and ceramide will reduce the formation of glucosyl ceramide, miglustat and eliglustat, significant improvement in symptoms, and this advantage is oral drug. It is an oral drug, but mind it, cost is almost equivalent to ERT, because daily you have to take oral. So monthly cost is almost equivalent to ERT, but only thing is you don't have to take an intravenous infusion. So I think so many patients who have started IV therapy in adult patients in India. I don't have any personal experience with the miglustat, so any of my patient is not there. But in India, so many patients are there in the substrate reduction therapy. Madam will have experience with significant improvement. Then another area is the HSCT, hematopoietic stem cell transplantation. It is very important area where you can give thalassemia, lysosomal storage disorders like MPS type 1 in first 2 years of age, before significant abnormal development. Then adrenoleukodystrophy in early stages, especially it's recommended for the second child. You have to do the MRI early itself, and early neurological signs. Before developing neurological signs, you can do the HSCT. Then large lot of immune deficiency disorder like SCID, chronic granulomatous disease, Viscout-Ulrich syndrome, etc., osteopetrosis, and Fanconi's anemia, and so many bone marrow failures. These are all genetic conditions where hematopoietic stem cell transplantation will work. Then organ transplantation, like liver transplantation in tyrosinemia, glycogen storage disease, some of the glycogen disease. Type 4 definitely may require, because type 4 is the condition where early cirrhosis will develop. By 2 to 4 years, patient will develop early cirrhosis. And type 1 and type 3, depending upon the hypoglycemic episodes and development of liver symptoms, all patients may not be required, but sometimes MSUD, then organic acidemia, urea cycle disorders, etc., where dietary therapy fails, you can plan for liver transplantation. One of the important condition is tyrosinemia and Wilson's disease. I have not included here because I have included more of a pure. Wilson's disease is another major condition which you require. Tyrosinemia is one condition. And kidney, ARPKD, ADPKD, Fabry's disease. And another important thing is liver kidney transplantation, especially primary oxaluria. Primary oxaluria usually will present as the kidney stones. And once you diagnose, if already kidney damage has occurred, you have to do the liver kidney transplantation, because basic pathology is in the liver. Basic pathology is in the liver. So kidney is damaged, nephrocalcinosis is there. Without diagnosing, you have done the kidney transplantation. In that kidney, again, disease will recur. So in primary oxaluria, it is actually a liver kidney transplantation. But before developing kidney damage, that is 2 years, 3 years, if you identify, you can do liver transplantation without doing kidney transplantation. Liver transplantation is the treatment of choice. And some cases of methylmalonic aciduria also, sometimes you may require a liver kidney transplant. Then finally, the gene therapy. Gene therapy is our aim, where we are correcting the entire gene. So gene therapy can be a gene augmentation therapy, just for understanding various forms of therapy, just for writing a short note or something like that. Gene augmentation therapy. Gene augmentation therapy is very simple. So when there is defective gene, we are augmenting the gene. We are administering the gene. Like Soligen SMA. Soligen SMA is 16 crore, 18 crore. Actually, it is a vector, AAV vector, just like COVID vaccine. We are actually giving the vector will be associated with this defective gene. Gene will be given, vector will be replicate. The gene will be impregnated into the area where, and it will produce the protein, and disease will be. So gene augmentation therapy. Then antisense oligonucleotide, where it can be a conventional ASO like SMA therapy, nusinersen, or some of the DMD therapy, etc. Or small molecules. Pharmacological molecules can also act as a antisense oligonucleotide like classical risdiplam. Risdiplam is actually a pharmacological molecule, but it is actually acting through antisense oligonucleotide mechanism, increasing the SMN2 gene. Right? One slide is there about the SMA treatment. Then root through stop codon, where there is missense mutation, suddenly stop it. Then you can read through stop codon like Ataluran, PTC123, etc. Then RNA interference is there. Then gene editing is the newest methodology, where there can be through CRISPR-Cas you can edit the gene, so that is much more advancing and interesting. We can correcting. We are not augmenting. We are actually going inside the body and correcting the gene. Wherever mutation is there, we are correcting it. So success stories of gene therapy. First, we have to tell spinal muscular atrophy, because I think most of the people, actually it is not the first molecule came, but people know spinal muscular atrophy because of the hype creation and social media and paperwork, etc. cases, and most probably because it is one of the highly magnitude common conditions, because rest of the condition, if you say Leber's congenital amaurosis, it is not very common. Whereas if you consider all these conditions, spinal muscular atrophy is one of the common condition in ZPGA study itself. They have identified that it is 1 in 38 to 1 in 40 is the carrier status. So it is a significant magnitude is there in our country. So definitely carrier screening as well as the treatment options for spinal muscular atrophy should come. And I think anybody who have seen one SMA patient will not forget the feeling, or what you can say. We have done SMA clinic has been started. We have started risdiplam also. We are giving for 43 patients now. Yesterday also one doctor child got SMA and they called me. A result came and we have to start risdiplam. So 8-month-old. So SMA is a very comparatively common condition. I think it is 15 years back also is like that. When we studied MD in 94, 97, only one condition which we can reasonably confidently diagnose is SMA. Apart from SMA, rest of the all conditions we will put into the one bracket, that muscular dystrophy, myopathy, everything together. Now, I will ask my PGs how to differentiate all those things after my DM. But for MD people, it is difficult. At least SMA and other conditions we should be able to differentiate, whether it is a muscular dystrophy and myopathy or SMA, because SMA is a very common condition. Then Duchenne muscular dystrophy, 3-4 molecules are there. Leber's congenital amaurosis, AAV2, gene therapies, subretinal injection. I know what is going to come. I think it's already came. They are planning to launch the molecule, or they are already launched and they are coming with the Aravind, because last 2-3 weeks I was in Aravind. So they were discussing this about this few patients and regarding this molecule. They are also included in the trial. Thalassemia, hemophilia B is adeno-associated vector. CMC Bailur is also, and MRI they have identified one thing, and the phase 3 trial. Achondroplasia vosoritide is already there. It's already there, above 5 years we can give, but it's not available in India. Cystic fibrosis, IVAC after, so many molecules are there which will increase it. Immunodeficiency disorders, neurofibromatosis, so many that MAC inhibitors, those lines, malignancy, infectious disorders, cardiomyopathy. So there are so many success stories, but it doesn't mean that. That's the thing I want to tell. Because when you go out, don't tell patients also. When you're counseling the patient, you have to give the correct, real idea. Because now the social media and everything, information is there. Some patient will see that, Duchenne muscular dystrophy, I should get that medicine. They will come into the queue and they will give the court case, and this medicine is somewhere available. Why can't government can give? Government has to give support. It is one injection costing 40 crores, 50 crore, whatever it may be, they don't bother. And court also feels like that. Judge will tell it is right to leave. His response, right to leave is the right of the person. So we have to treat whatever the cost. So unnecessary pressure. So first itself, when you counsel, you should tell that these are all under studies. Because otherwise patient also feels bad. Because I'm having experience in Kerala, one of the pediatric neurologists, he has given in a small paper, Soligin SMA. Soligin SMA, that is actually SMA gene therapy. And this poor father is going pharmacy to pharmacy asking for Soligin SMA. It has happened and they have given case. So that should not happen. These things are available. Things are moving on. In last, I am also from 2004 in the genetic field. So last this much years, so many new things. As I told, this much success stories. I don't think in my first presentation when I have done doing my DM, I have done my presentation. At that time, when slides are not there. In the transparencies, I have written and presented. At that time, only 1 or 2 ERT gene therapy may come. We will hoping like that. But now we know that it is going to come. Next 20 years, there are so many molecules going to come. That is sure. But don't give false hope. And people will feel that it is. For example, SMA also, you know. I think SMA, I think one slide I have put. Single dose gene replacement therapy for spinal muscular atrophy. Definitely, NEJM, it should come, means there should be some response. Because it's a breakthrough thing. Geneticists like us also felt. Still, I am remembering when this came, madam has phoned all of us and discussed. SMA treatment is coming, definitely, so many treatment came. Correct. But patients should not feel that next day I will get the SMA and next day my child will run after taking one injection. That you should tell that. There are so many limitations. In Malayalam, we will say Balarishtada. Balarishtada means in children always difficulties. They will fall, again got up, again start, again fall, again got up. So SMA is now like that. There are so many down and up and down and up. After 10 years, you will get a very good molecule with excellent response with less cost. So when you are working as an academician or a science interesting person, it is a breakthrough. There is no doubt about that. But that doesn't mean that immediately all of my SMA patients should get this shot and they should run tomorrow. Doctors also feels like that. That is a tragedy of it. So doctors should understand that these are all beginning things. There are so many limitations, so many things has to happen that you have to counsel when you're counseling it. So spinal muscular atrophy, there are 3 molecules. First approved FDA in 2016 is nusinersen. It is an antisense oligonucleotide. It is intrathecal administration, continued therapy lifelong, approved for all types of SMA and all ages, and it is available through some of the patients in compassionate access program. Soligin SMA is a single shot gene therapy, approved by FDA in 2020, viral vector gene augmentation, single IV administration, approved for SMA type 1 in children, because their outcome they have studied is in type 1, most of the children will die by around 1.5 years. So their outcome was, it will prevent mortality, it will prevent long-term respiratory support, ventilator support. That is 100% definitely, because I am also having experience. We are also giving for 43 patients, so many patients are type 1. In last 15 years, all my type 1 patients have died by around 1.5 years maximum, usually around 1 year. But now I am having 3 years, 4-year patients with type 1 because of risdiplam. Because they are not getting recurrent respiratory infection, their mortality is prevented, some amount of improvement in motor function is there, but still they are having significant motor delay. Significant motor delay. And that you have to counsel them. And now those patients, they have got compassionate access program. They are very much worried. Why we have given there is no improvement, no. At that time, they told, even if it is prevent mortality, it is good for us. I totally agree. Parents' feeling always will be there. Even 5% benefit, parents will be happy. I 100% agree their feelings. But we have to be in between. We have to talk to them. We have to discuss with them. And risdiplam is approved by FDA in 2020. Small molecule with the ASO, orally, daily, lifelong, approved for all types of SMA and all ages. It's available through compassionate access program as well as launched in India in 10th July 2021, DCG approved by Roche, and it is available in the market. We are giving for our 43 patients. Risdiplam, it's a working through. Who told?
They are not giving the medicine for 2%.
No, that is actually, frankly speaking, nobody can write because it is very costly. One bottle costing lakhs. So who's going to buy in the market? Nothing. So in every state or every hospital, it should be by a group of doctors who should decide it. That doesn't mean that pediatricians should not write, but practically it should be a committee decision. For our part, it is the pediatric neurologist and pediatrician bar geneticist. You can include me as a pediatrician or a geneticist. Both of us are deciding on the which patient treatment should be started, and all things will be ratified in a bigger committee where DME also is there, Director of Medical Education, because it's a very costly drug. Even I don't have any take a decision to order a drug of 6 lakhs as per administrative sanction. So it's a committee decision, but practically decision will be taken by the pediatric neurologist and geneticist in our hospital. In any hospital, I think a pediatric neurologist or a geneticist, a group of doctors are required. Single patient, it is not a. But nowhere it has been written, prescription has to be given by the pediatric neurologist. That I think probably the company people to unnecessary problem avoidance, I think they would have been created like that. No, nothing like that. Nothing like that. No legal formalities like that. But most probably nobody can write and nobody can buy. It has to be through a government system or a charitable access system, something like that. Gene editing is already I told. It's a clustered, regularly interspaced short palindromic repeat. That's a CRISPR technique where a genetic engineering which DNA is inserted, deleted or replaced in the genome of a living organism using engineered nucleases or sorry, the spelling mistake or molecular scissors. Just I have covered that. That's all. There are so many issues of gene therapy like optimum dose of the vector and its passenger gene necessary, specificity, control of transgene expression, adequate margin of safety, the interaction between the novel genes. For adequate margin of safety, one classical example is the Gaucher disease. Gaucher disease, we are having there are new molecules. In Gaucher disease, they are having some gene therapy molecules. Gene therapy included gene therapy molecules they are trying. But problem is already a standard of care therapy with excellent result is there. So to which patient you will change this? Because in a drug trial, these issues are there. So that is some of the thing which is very difficult. And for a completion's sake, prenatal therapies are there, like prenatal medical treatment, biotin deficiency in maternal biotin, congenital adrenal hyperplasia. But now we are not using it. It's only a theoretical perspective, dexamethasone. But we are not using it because now we are doing prenatal diagnosis. We are not even counseling them. We are not counseling. Some people are, we are not counseling. Totally we stop. That means in congenital adrenal hyperplasia, we can give steroid to prevent the clitoromegaly in a female patient. But that is a classical example of a fetal therapy because you are giving medicine to the mother. The steroid will go to the fetus and it will prevent the clitoromegaly in a female child. Previously, when prenatal diagnosis is not freely available, we were using this option. But disease cannot be prevented. Clitoromegaly in a female can be prevented. Okay, so there is a protocol is there when should be started, when you should do the sexing testing. Sexing you should not tell, only tell you have to continue the medicine or not. When I went back from here in 2010, 2-3 patients I have used this method. Then after 2013-14, this NGS came everywhere. So many companies are using NGS. So many prenatal diagnosis facilities are there. We are not using it. We are doing only prenatal diagnosis. We are not using dexamethasone. Then fetal cardiac failure or arrhythmia, still digoxin, because now that is more commonly we are using. Digoxin is using. Digoxin or sotalol, so many drugs we are using, cardiologists. We had surgical treatment, diaphragmatic hernia, hydronephrosis, just for a completion's sake I have put. But finally, most important thing is genetic counseling, because preventive aspects and genetic counseling and prenatal diagnosis you should not forget, because therapy is there. You can do a lot for the patient. So that feeling should be there, because if that is not there, when you are doing prenatal diagnosis, immediately if some SMA patient, you have done the prenatal diagnosis. Sometimes mother may not be willing for termination. You will get irritated. We have done prenatal. I have told you. You are not understanding. So that is not like that. Everything should be their decision. Even if something happened like that, you can be with them, help them, support them, whatever possible things you can do with them. This is, I think, last slide. Rare disease policy. The same treatment has been classified into 3 headings, but now these 3 headings are not there. Just only for an understanding thing. Amenable to one-time curative therapy for HSCT, LSCT, long-term, lifelong treatment having relatively lower cost, and diseases for which definitive treatment is available, but challenges are to make optimal patient selection. You can go to the Rare Disease Policy 2021. Everybody should read this Rare Disease Policy 2021, these diseases, because definitely somebody will ask you, if you are trained in this, people will ask you. So therapy in genetic disorders can be considered in different levels. That is the theoretical constraint, 3C concept, and 6 levels of therapy. That is the most important thing. So many success stories and so many things which we are routinely using, I have told. Concept of ERT and gene therapy, And prevention and genetic counseling is important. Rare disease policy should never forget the preventive aspects, like so many preventive aspects, good antenatal care, right? Or all those things also you have to. Thank you very much.